Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to be with us, and we will launch in without further ado after I turn things over to our founder, Dr. Randall Maxey.
Good afternoon, everyone, and thank you for joining us on this lovely Sunday afternoon. We have an interesting topic. My mind has been on the word life expectancy for a while, and I wanted to interweave this in with what we've been talking about with nutrition. But I have an unfortunate announcement. One of my very good friends and former board member at the National Medical Association and at one time was candidate for chairman of the board, who was from Philadelphia, Pennsylvania, passed this weekend. His name is Dr. Walter Wren. And I really liked Walter. Most of us did. He was a very outspoken gentleman. And I'd like to give honor to him and pass on condolences to his family and friends. He's a great member of the NMA. And why it was so significant to me, we were almost exactly the same age. And I've been very conscious of my age now. Every day that I wake up, I thank God that I'm on the right side of the grass. But let's go with our set of slides today, Simon, and our topic. And if I ask our co-moderators to join me in working with the slides with me. So I titled the Decline in Life Expectancy in the United States. We're going to look at racial issues, regional issues, social and biological factors as well. Next slide, please. So, why is American life expectancy declining? This is a discussion, and I invite our listening audience to join in, put questions or comments in the chat, and at the appropriate time, we can even unmute people to join our discussion. Next slide. So, an overview. Over the past decade, U.S. life expectancy has been a troubling decline. After peaking in 2014, it has dropped significantly, particularly during and after the COVID pandemic. This trend contrasts with peer countries where life expectancy has mostly rebounded. Next slide. So, life expectancy is a statistical measure of the average time a person is expected to live. It is influenced by many factors that include genetics, healthcare access, income, education, environment, and lifestyle choices. So we're very important that lifestyle choices is always important. Your genetics are important, but so is how you exercise your life. And this was quoted in the World Health Organization in 2023. Next slide. Uh, Dr. Neighbor Stevens, help me with this slide.
Sure. Statistics from 2020 through 2024 show that U.S. life expectancy fell from 78.9 years in 2014 to 76.4 in 2021. This decline has been most pronounced among Black, Native American, and Hispanic communities. Drug doses, chronic diseases, violence, and COVID were major contributors.
So you want to comment on that? I know you're a pediatrician. You don't deal too much with death, but
More than you would expect, unfortunately. And I just was reading this week that the studies are showing that we really have to look at where the child lives to really understand and predict what's going to be their health outcomes. So this supports all of that, and I'm sure we'll get more into that. But where you live as well as how you live have
Mm.
very direct effects on life expectancy.
I heard on the broadcast this morning that some of the children in Gaza uh, that they have a lot of diarrhea and a lot of diaper rash and infections, and that diarrhea is one of the things that is the biggest cause of death for children under 5. I wasn't aware of that.
Yes, it is. And it's not helped any by the fact that they are starving and the quality of the water that they're drinking. So, but rotavirus was until they developed the vaccine for it, a major cause of death for children in the third world.
Mm. Thank you. Next slide.
Why is this happening? Well, there's an increase in drug overdoses, especially opioids and fentanyl. There's a rise in chronic diseases such as obesity, diabetes, and heart disease. There's a mental health crisis in this country with resultant suicide and morbidity, healthcare disparities and unaffordable care, as well as access to care, I might add, and social determinants, poverty, racism, and stress.
So, in discussing this slide, uh, I think the thing that jumps out on this, and maybe Dr. Walks might want to comment too, is what's going on with these overdoses, opioids, and suicide, especially the mental health crisis that we see going on. Is America going off the deep end, Dr. Walks?
Well, with Dr. Maxey, I don't, those are a couple of different questions. Is America going off the deep end? And then are people individually having challenges with their mental health? A lot of times when we look at the overall behavioral health challenges, that includes mental health stuff, it includes substance use stuff. And so when we look at um, overdoses, just this past couple of days, there was a major news story about overdoses in a certain part of Baltimore, um, Maryland, just in one neighborhood. I think it was 25 or 27 people who overdosed from what is being referred to as a bad batch. So folks got some bad drugs. Several people, I think 5 or 6, wound up in the hospital and in really bad condition. And what's disheartening about it is that it's being referred to as a bad batch as if there's a good batch, right?
Mm.
So we can have people using substances that don't really help them at all. Um, and so now that those same substances that can kill, people are getting too much and they are dying from it. It indicates a really big problem in our society because one person was telling me, "Oh, well, you know who's really mad about it is the people who are selling the drugs, because if somebody mixes up a bad batch and kills their customers, that's bad. If
Mm.
somebody mixes up a bad batch and it makes the news, then law enforcement may become more involved, and that's bad for business." None of those conversations includes the fact that people are losing their lives using these substances. And as our country becomes less and less sensitive to people's needs and more hostile towards diverse communities with diverse challenges, this is a problem.
The other thing, Dr. Walsh, is notable in this, with it's not only a bad batch, but there's something called drug tolerance. That
Mm.
sometimes you use the drug so many times that the hit that you use 1 gram for now doesn't give you the same high. That's called tolerance. So you think you need more. So you up your dose, and there's a very low margin between upping the dose and getting the high that you want, and it actually having a toxic and possible fatal dose being given. That's called tolerance. So that's something we have to look at. Well, if one did me this, maybe two will make me even feel better, and that's dangerous. I don't know if Dr. Lawson's on. I don't know. He's a pharmacologist as well. Is Dr. Lawson on as well?
He's on.
Yeah, I'm here.
Want to comment on that issue of tolerance and how?
Yeah, tolerance is a well-known phenomenon. And one of the problems that's happened recently is that we've been going around telling people that, here's some naltrexone or Narcan and others. So, and especially in DC, the way they were dealing with some of these opiate use problems is to making Narcan available. And we passing them to churches and everywhere else. The problem is that it doesn't treat the problem. And what we find is that if you get early enough for a lot of these folks that get the Narcan, they essentially do not develop the tolerance, and then they'll go out and use later and die from what was used to be a useful dose for them. So this is an example of one side of this. It looks like a solution, but in fact it's not. And the other part that you mentioned, that people drug overdose doesn't address the problem. And Dr. Chapman has been pushing this for a long time. The fact is that, and we've also found out from the experience with marijuana, where some of the states went up and legalized marijuana and said, aha, we can deal with these problems. The problem is that many of the consequences of drug overdose of drug use is not just immediate, somebody drop dead in front of you, but also the long-term effects. And we're beginning recognizing that the long-term effects of some of these drugs will produce all the chronic diseases that we've talked about, because people do not take care of their health care. They do have long-term adverse effects on the body. We found now rediscovering that while you won't overdose and drop dead on marijuana, it is not safer than smoking cigarettes. So there's long-term effects. If you left out pulmonary disease, the African Americans tend to smoke less, but now they were much more likely to die from cancer from nicotine, from cigarette smoking. So it's not just a problem of who's driving dead in front of you, but there's a long-term contribution to life expectancy that's just as important.
The question I asked Dr. Walks earlier, and I stated in a way that might have been over the top, but is there more mental illness in America over time than previously, or we just know how to find it better?
I think we're finding it better now. If you go back, and I've made this point repeatedly, if you look at it, up until recently, up until Dr. Husant and others made the point, we were saying that Black people did not get depressed, Black people did not get anxiety disorders, and now we're finding that the U.S. is one of the leading countries in the world in terms of depression because we screen for it. People's Republic of China always score very low in terms of depression rates, but their suicide rates are about as high as everybody else. And the reason is that they don't call it depression. So we're doing a better job in having people recognizing what depression is, what anxiety is, that there is that post-traumatic stress and others. But it wasn't that it wasn't there before. It's been there since slavery times. Now hopefully we can do something about it.
No, thank you very much. Let's go to the next slide, Simon. So, Dr. Neighbors-Havens?
Okay, the role of social determinants. This is short for social determinants of health. Life expectancy is heavily influenced by where you live, your income, education level, job type, access to healthy food, and clean air. These structural issues drive many of the negative health trends seen in the United States. One of the classic examples of this was a study done, over 25 years ago now, where the prevalence of asthma in Black children was investigated, and it was directly related to their proximity to living near a major highway. And this research was uh, part of the effort to move toward lead-free gas to decrease some of the toxic if toxic effects. However, I have to say, as I visit different cities and I see all of these high rises that developers have put along interstates, I keep wondering what is the health impact of living near these highways?
That's true. And they always build them right through our neighborhoods as well. Dr. Walton, you look at the next slide.
I was just going to add that at this point, your zip code can be more of a predictor of your life expectancy than even your genetic code or immediate family history.
Well, I'm sorry, Dr. Hines, I didn't know you're here. Glad to hear your
Yep.
melodious voice. That's good. Will you take the next slide, Dr. Hines?
Sure. Key drivers of decline by race and ethnicity. Black Americans have increased cardiovascular risk, violence, and maternal mortality. The Latino population had an increased COVID-19 mortality and essential worker exposure. White Americans have increased opioid overdose and suicide, in particular, deaths of despair. Those are the ones like the ones that things are like alcoholism and those types of things. Native Americans have a high rates of diabetes, suicide, and substance abuse, and Asian Americans have the lowest decline, but disparities by subgroup and income exist within that very diverse community as well.
So this is interesting in that they've separated out what are the big problems, but we know they're across the board as well. And I think there's a graph after this. Go to the next slide, Simon. Can you talk about this graph, Dr. Hines?
So sure, this graph is a visual representation of the life expectancy by race and geography. So, and what it's showing is the y-axis is the number of years of life expectancy, and then the x-axis is the different racial groups, and it shows that Asian Americans have the highest. This is from data from 2023, and that Asian Americans have the highest life expectancy with a little over 80 years old, and then you see Native Americans with the lowest life expectancy, looks like in the mid 60s or so, and followed by African Americans at around 70, and then whites at maybe about 70, little over 75, and then Latinos closer to 80, look like 79, that area. I think some of these types of things are also contributing where Caucasian Americans are not at the top of the scale of are contributing to some of the things that have led to our social and political climate, right? Like it seems like they fear they're having a loss, right? Their loss of their top tier status, and that's a problem.
Yeah. And they're always concerned about birth rate too.
Oh, for sure, right? Because I mean, and so there's a lot of discussion over that study that said that I think it was in 2050, I think it was that Caucasian Americans wouldn't be the majority, and there's a lot of people that point to that as a really big inspiration behind some of the intensity of the MAGA movement and the birth and this whole, we've got to have more babies, but only certain babies.
Yeah, yeah. Let's go to the next slide. Dr. Walsh, you want to take this one?
Absolutely. Socioeconomic status and life expectancy. First bullet. Income predicts access to healthcare, housing, food, and environment. Education level influences health literacy and preventive care. Poorer Americans experience higher chronic disease and infant mortality. The wealth gap directly contributes to longevity disparities.
And there's a graph right behind this. Take the next one too, if you would.
So if what I'm okay, so socioeconomic gradient in mortality, life expectancy by income quartiles. This is from the Journal of the American Medical Association, 2022. The short version of this, from those of us that went to public school in LA, is that the more money you got, the longer you might probably live.
So Dr. Lawson's gonna live forever?
Well, he might. If Dr. Lawson doesn't stop eating those bison burgers, that might knock a few months off of his life expectancy. But no, I mean, look, I think that sometimes we have to just stop for a minute and go, okay, we know this, right? And it is really a challenge for us to continue to let people act like, and sometimes we say things on Black Health Trust, and I just want to be very clear. I don't think that any of us on Black Health Trust have a problem with white people versus Black people. Our challenge is that the people who are making policy tend to be wealthy white people, and some of those wealthy white people really have a problem with a lot of the things that Dr. Hines mentioned just now. So this isn't only about race. This is about people who don't care about us and who would love for us to continue to be poor and die early. And they happen to be making all the policy right now.
Okay, let's go to the next slide. Dr. Lawson, you want to take this one?
Sure. Geographical and regional disparities. Southeast stroke belt, high hypertension, stroke, obesity. And I can quickly say, coming from Virginia, that almost everybody in my hometown has hypertension and diabetes. Midwest, opioid crisis, smoking, suicide rates, rural areas, limited health care access, provider shortages. Now, then what they're not in provider shortages, but also specialty care in rural areas is going to get a real hit when the new Medicaid cuts go in. And urban areas, chronic stress, violence, environmental risks. And you didn't mention this as one of the big killers in our community, but again, the homicide rate in the African American community continue to be high. Although the good news recently is that the rates in Baltimore dropped by about a third, and I was very glad to see that. So something can be done by it. But again, homicide is laying right up there with suicide in terms of still killing many of our young people.
You want to comment a bit about that first bullet? Why the Southeast is stroke belt and high hypertension? Any thoughts on that?
Well,
Any of our co-moderators?
yeah, by the way, I went back to my hometown and decided I was going to drink me a diet soda. None of the grocery stores had diet sodas. To try to find a Subway, could not find a Subway. So part of it also is lifestyle and the emphasis on a high-fat diet, that obesity is not a problem, and that if your blood pressure is a little high, well, that's how it is.
But let me comment on the diet soda. In my opinion, and from the research I've done, if I'm going to drink a Coca-Cola, I'm going to drink a regular Coke and not a Diet Coke. There's a problem with the Diet Coke in the fact that with the sweetener in there, that gets to something called your glutamic oxide pathways. and it prepares your body to hold a big uh, intake of calories, which you're not getting. And the calories you do get go around your waist, and it's actually more fattening than is a regular Coke. So I encourage people not to drink diet sodas. If you're gonna drink a soda, you'll be better off with a regular soda, even if it's a Coke and can shine your pennies. So there's something called the cephalic syndrome. You can look that up, and it's a major problem. I don't know if Dr. Gibson is on. He might want to comment on
Let me
that.
just mention that I was doing some research a couple of years ago, which we were using the animal models, trying to look at the impact of artificial sweeteners added to glucose versus eating glucose alone. And what we find is that artificial sweeteners actually interact with other sweeteners to make the foods more desirable. So the diet sodas actually encourage the excessive use of other caloric elements, and not only are you fooling your brain, but you're also enhancing the value of the more caloric food. So that's why diet drinks don't work, because people overcompensate by eating more caloric foods when they have those.
Okay,
Just
which I think begs the question, Dr. Lawson, why were you looking for diet sodas in your hometown? I'm going to ask the tough questions.
You go to Beisenberger.
No, I look, it is that we live in a society where it is very, very challenging. And that's why programs like Black Health Trust are so important. It's really very challenging to just listen to the mainstream media, read the mainstream publications, and know what you should do and what you shouldn't do. It's very challenging. So.
I did just want to add a little bit to that. Why is it the stroke belt? And in particular, the stroke belt is largely referring to like North Carolina, South Carolina, and Georgia. But when you say the Southeast, oftentimes people think of the coastal states, but you're not thinking about Kentucky and Tennessee sometimes, Alabama, as Arkansas, right? Where in addition to, having diabetes and high blood pressure and obesity, don't forget also about smoking and some of the poor diet and physical activity things that also come around, as well as poverty and economic hardship that exists in that area. And then that is compounded by, there's the legacy of, structural racism and generational, health patterns around seeking care and food choices, and all of those things kind of contribute to why that particular area has become known as the stroke belt. There's absolutely a cohort of chronic diseases that are known in that area that are not with the same distribution and frequency than if I picked if I picked Idaho, North Dakota, South Dakota, it's different. And that's why culturally competent programs, public health grounded programs that are, socially and structurally designed for those communities is really important.
The other thing that I believe historically, there's a difference in the soil in the Southeast that promotes hypertension, whether it's the silicates or the minerals that are there. It has to do with the vegetables that are actually grown there. So there's also a geographic and regional difference in the soil that can affect your blood pressure and the plants that are grown in that area. If there are no other comments on this slide, let's go to the next one.
I just
Before
want
you,
to quickly
be-
note
before
you raised an excellent point. Not on that, there's some of the rare elements that are lacking there too. Pica is very common in that part of the country. And part of it is that folks aren't getting enough of the appropriate electrolytes and others.
Explain what pica is.
Oh, I'm sorry. Pica is supposedly a preference for non-organic foods. It's really eating minerals and salts like clay and others. In some parts of the South, it's considered.
Orgo starch, right?
That's right. Starch. It started out with starch, but folks also some of the areas eat a lot of clay. And again, they're trying to deal with some of the calcium and the sodium deficits that they have.
And Dr. Gibson did have a comment, Dr. Maxey.
Dr. Gibson?
Actually, that is, thank you, Dr. Walks. I have to make a comment on the mineral difference in West African soil. You see, Black people come from primarily the western coast of Africa. The chemistry of the soil is very, very different than the chemical content of the soil here in this continent. So for that reason, I say it is even more important that close attention be given to the mineral content of the food, which is why salt-rich soil versus other soil that might be taken for just hard clay is very, very important, because that's going to determine what the content, mineral content of the food is. So, as Hippocrates once said, let thy food be thy medicine, let thy medicine be thy food. That's very apropos for today, because if we eat well, if we could, because why is it that food deserts coincide with pharmacy deserts in this country?
Hmm.
That is a very perplexing and disheartening reality that we have to bring from the back of the mind to the front of the mind. I rest counsel.
Thank you for your comments. Dr. Hines, would you, with your young eyes, look at this slide?
Sure.
I don't always want to tease you about being the youngest of us, but I do.
So this one is the regional life expectancy map, and is broken up into Northeast, Midwest, South, and West. And it looks like the Northeast and the West have overall higher life expectancies, both of which are around 80 years old, followed by the Midwest at looks like the mid upper 70s, and then the South has the lowest life expectancy in the lower mid 70s.
So if you want to live long, come to California, right?
Maybe.
What are some factors that would make this true? I mean, we're looking at trends, we know they're averages, and so it's not absolute. But
It's interesting too, because like this data is from 2023, and I would be curious what a forecast like this same kind of data, but in a forecast version would look like. I would be curious if in 2050 they predict that that distribution would be similar. I don't know.
that would be very interesting.
Mhm.
Very interesting. And we have the references here, so we can go back and see some of the charts out of these journals.
Well,
Steve,
maybe,
go ahead.
maybe we can, because I'm sure that the people who do this research and make these charts at the CDC,
They're all fired.
right? Yeah.
So they won't
And-
be here next year, right?
Well, I mean, I think that this chart goes hand in hand with the chart we saw earlier, which looked at life expectancy with respect to resources, right? Because if you look at the West and the Northeast, specifically, if that's represented by places like California and New York, Boston, and what have you, you're going to have higher cost of living, higher income. You're going to have a higher concentration of some of those major academic institutions and healthcare institutions. And so, I mean, there are some other places, but not the same concentration you find in Boston, New York, and LA, San Francisco. So yeah, I'm always frustrated that sometimes people think that there's a big mystery here. There's not a big mystery here. I mean, if you don't have money and you live in a food desert, it's a challenge.
Is there any factor in being near an ocean?
Yeah, it costs more to live there, so people that have money live on the coast. I mean, that why do you think Dr. Lawson is not still in Southern Virginia someplace? He's he's up here where he can get to the beach in less than 2 hours.
Okay. Let's go to the next slide. So, Dr. David Stephen, maybe you can deal with this one. I see one of your favorite words, machismo.
Yeah. Gender norms and the role of machismo. Males less likely to seek care early or report symptoms. Toughness associated with delaying treatment. I I want to come back to that one because I kind of disagree with that. I think that's a misrepresentation of what's really happening. Higher rates of violence, accidents, and substance use in men, and Black and Latino men particularly affected by cultural stigma. So I don't think it's toughness that is the delaying the treatment. I think that chicken.
It's showing that they want to show that they're tough, but they're not really tough.
No, she's saying they're afraid to find out.
Yeah, they're chicken.
Afraid to find out and afraid to deal with it is the point that I believe Dr. Nabert Stevens is making.
And
I thought chicken was very clear, but thank you. We have to explain the meaning of chicken now.
I'll let the two psychiatrists come down on this, but I think part of it is wanting to appear strong on the outside and that you won't have illness and things, but on the inside you're scared to death. But Dr. Lawson,
Okay,
comment on that?
Dr. Lawson wants to help out the men. Go ahead, Dr. Lawson.
Well, I think part of it also, though, is understanding why do you have problems and why are you ill? A lot of guys simply believe that if you don't talk about illness and you do not mention it, you will not feel it. You see this in a lot of athletes. You see this in a lot of folks who uh, work work outside and so forth. That illness is because you think about it. If you don't think about it, if you ignore the pain, if you ignore the distress, then you will be fine. And the working mantra is, if you have pain, walk it off. If you have cancer pain, well, you can avoid the cancer pain by just ignoring it, and it'll go away. Got a toothache? Wait till the tooth falls out. Don't worry about it. It'll go away. So it's toughness in the sense of a focus of trying to ignore, of being taught that pain is the problem and not the cause of the pain. And so if you ignore it or don't do anything about it, then your problem is going to go away.
Dr. What do you think about the outside show of toughness? Like my men don't like to cry or be seen crying.
Let me first of all support everything that Dr. Gibson, that Dr. Lawson just said, and say that Dr. Gibson also raised his hand to make a comment. There, as someone who is a military veteran, there are a lot of opportunities for men to be taught that pain is not a sign of anything but the fact that you can't handle pain. That's what it is. The old military, rub some dirt in it, keep it moving. It's not okay to say that something hurts. It's not okay to say something feels bad. And so there is that, we can call it machismo and blame the victim, or we can call it an indoctrination or an acculturation that happens to a lot of men where, and it happens with young boys when they are playing sports or any sort of a thing where they're on the playground and you fall down. We want to pick the girls up and coddle them, which is not the best thing for them either. But for the boys, we say, "Oh, come on, you're gonna be fine." Be a man, grow up. And so I think we just have to address this in a way that acknowledges that you don't wait until a man is 40 years old and blame him for not getting checkups. And then let's put some of the blame on the doctors who love to treat the symptoms. You come in, and especially if you look like an African American person, and you might just get some pain medicine and get sent home. Something is hurting you, and you get, take some Motrin. The same level of exploration that other folks may get, we don't get.
So let me ask you,
because we go to the ER, but what are you going to do?
Let me ask you a
I'm-
question, and let me ask of all of us who are parents, especially males, do you hug your sons the same way you hug your daughters?
Personally, me?
Yes.
Absolutely. I grip up my son, I grip up my grandson because I want them to know that it's okay to be a man that shows affection, just like I tell my daughters that it's okay to look for a man that knows how to show affection and how to be caring.
Excellent. All right. Were you
Bef-
about to say something, Dr. Hines?
Yeah, I would also just to your point, Dr. Walks, about acculturation, in general, women overall are exposed to and expected to engage with the healthcare system with a much greater frequency throughout our life course, whether for ourselves, because we have gynecological care, that things that are expected of us earlier on that continue outside of adolescence. Like, so for most kids, fine, everybody's going to the doctor with the same relative frequency as far as preventative care is concerned. But then if you're a boy, that kind of drops off, right? But for ladies, whether it's for gynecological care, birth control things, there are things that keep us engaged kind of throughout the course of our life. And even when it's not us that we're getting care for, we're taking our kids, we're taking other people. So women, I think, are cultured to engage more with the healthcare system, like it or not, than men are.
Let me,
And as a mom, yeah, I hug my daughter and my son, whether.
Dr. Hines, let me ask you one more question. There are many women whose only physician or contact is with OBGYN.
Yes. Because, and I think for a period of time, depending on what and I'm saying this as a family medicine doc too, right? For a period of time, depending on your age and your circumstance, and of course your doctor, that can be very appropriate. There's a reason why OBGYNs can qualify for some of those, private primary care provider shortage grants and programs and things like that, for that very reason. Because if I'm 25 and healthy, then why the likelihood that I'm going to go see somebody else an issue that I don't have, when the majority of my preventive care things at that age can be addressed by my gynecologist, it makes sense. The question, as you get older and if you develop more chronic diseases, then you and your gynecologist kind of have to have a talk about how far your gynecologist is willing to go into some of these other spaces, because some stay just in that specific gyne wheelhouse. Some will order your colonoscopy because you're my patient. Some will check your thyroid because you're my patient, right? And just see. So there's a point where I think by 40, or if you're by 40, you should have somebody else. Oh, I'm making a generalization, but by 40, as a woman, you should have someone other than just your gynecologist, because the likelihood is you're going to be getting into some places where that may not be his or her wheelhouse.
I
Okay.
agree with what Dr. Hines is saying. I just want to make the point, though, that whether it's your OBGYN or your internist or whoever, you need somebody who is supervising and coordinating what's going on. Because too easily things become fragmented in our healthcare system. It's not a system.
Yeah.
Okay. That's
Let me
all.
just also mention, I think Dr. Walks may comment on this also, that and a lot of men actually end up going to get mental health treatment. But the problem is many of our mental health clinics have almost an aversion to dealing with health care. They do not encourage the folks that are coming there to get regular checkups. They do not encourage them to get regular screenings. And it's been a real challenge to go in and convince mental health clinics that just because that you are have that you want to focus on mental issues doesn't mean that your patients that you're dealing with don't get hypertension, diabetes, and all the other things that need to be screened for and watched for.
Well, thank you. Now, since you're on board already, would you take the next slide, Dr. Lawson, and you and Dr. Walker might want to comment.
Pathophysiological and biological stress mechanisms. Chronic stress raises cortisol, inflammation, hypertension, and I might also add that it also causes a shrinkage of the hippocampus, which we found is related to PTSD and so forth. Allostatic load, accumulated stress equals early organ decline. And I'll throw in again, this is especially seen in substance abusers who develop early aging by most measures. APOL1 gene variants in African Americans increase CKD risk. Epigenetic effects of poverty and trauma over generations. That's still a controversial subject, but you don't have to have a genetic mechanism to recognize that keep having multi generations of trauma that is not going to be good for the body.
Dr. Hines, Dr. Walks, you want to comment on this slide?
I just want to clarify that when we use initials like CKD, we are talking about chronic kidney disease,
Yes.
Dr. Maxson.
Yes.
Oh yeah, good boy.
Yeah, no, I think that again, this helps us in a couple of ways. One is it tells us that certain things that may not obviously be related, like if I'm in a very stressful environment, and we've done studies. I did some work back in California years ago that looked at the incidence of post-traumatic stress in certain communities and found that you just living in certain communities can give you the same kind of stress as being in combat, same incidence of post-traumatic stress disorder. So we those kinds of things we can understand. We don't always think about connecting them to inflammation and hypertension and kidney disease. And so I just think that when we look at slides like this that actually make that connection for us, it's important. You don't need to have 20 years of PhD or MD school to understand that things like this relate to each other and that they're bad for you.
So,
And I just want to add also that we talk about combat, living in an area in which you have high rates of homicide and so forth, it impacts the kids. There's been multiple studies showing that kids who live in some inner city areas end up with not only PTSD, reduced stature, hormonal changes, and also increased risk themselves of developing violent behavior later. And we find that African American kids in inner city areas get far less sleep than their other counterparts. And part of it is not only the sound of what's happening in the community, but also just the exposure of being in a situation in which folks are babysitting by putting them in front of a TV set.
what did you say about stature?
No, that contributes to short stature because of the reduction. Growth hormone is also hurt. The chronic exposure to loud noise and other stressors and excessive hypercortisol impacts the entire hypothalamic pituitary system.
So that first point here, that this cortisol leads to inflammation and hypertension, and that does affect CKD. It affects all those things. We talked about allostatic load, how that affects that. So all these things are linked, Dr. Walks, like you said.
Could I just
So-
add to that last bullet, the epigenetic statement, and Dr. Lawson, you said it's somewhat controversial, and I just wanted to, I think the controversy isn't necessarily that epigenetics exists, right? Where epigenetics is, how your genes are expressed or regulated without actual DNA sequencing changes and how that reflects changes, in your environment. Epigenetics has been linked to aging differences, cancer, environmental responses. But I think where some of the controversy lies is in how it's interpreted, how it's marketed, and how it's kind of applied, because now you have people selling supplements, and then what do you do with the policy impacts of epigenetics and determining risk and that kind of thing. But I think that the fact of epigenetics, that it is a essential part of biology, I wonder if that part is not really controversial. It's just what are we doing with the information?
Well, the question is whether or not you can actually produce DNA chains that can be that can be transmitted cross generationally. Theoretically, it is possible. We do have evidence now that you can have
It
methylization
may
of.
not have to affect the DNA per se, but it can
Right.
be the expression.
Right. It's the expression, right? It's the how they in my understanding of the term, it doesn't change the sequencing. It's just the expression of which things turn on, turn off, and that's based on like where the histones apply and all that kind of stuff.
No, I'm saying that we do have evidence that it can change the sequencing. The question is how often does it occur and whether or not it has clinical significance. But we do have evidence that takes place.
Okay.
So while all of you are very, very learned scientists and are giving all of this really great information, let me just take it back to the neighborhood, because one of the challenges we have in our community is that when young people, Dr. Lawson, you mentioned when our young people are in these violent environments. I remember going through my psychiatric training, and you probably got way better training than I did, but I never could figure out why kids had conduct disorder, but it magically went away on their birthday when they became an adult. Because adults don't have conduct disorder. See, you're laughing because it makes no sense, but that's what we were taught. And the problem is we label kids that come from challenging environments. We give them diagnoses that don't really allow us to care for them in a way. And so we lock young Black children in particular up in our systems because they're responding appropriately, scientifically appropriately, to these very challenging environments. And so I think maybe I'm a little bit too outspoken about it, but I think we have to just take this information that's on this slide, that's on this screen, and really try to impact policy, because we label our kids, we lock them up, and we don't try to help either the child or the environment. Both of them get just thrown away in these scenarios, and it bothers me. Having worked as a psychiatrist in a youth detention center, it bothers me a lot that again, going back to what we talked about earlier, all of the people who are making policy now don't really care about us. And so we have to really stand up and try to do some things and say some things and maybe elect some people who can not have what's on this slide continue to happen.
Thank you. Dr. Hines, will you take our last slide? Next slide.
So what can we do? We can improve access to preventative health care and mental health services. We can advocate for public health investments in clean air, food security, and education. And all of these things are currently under attack right now. We can promote healthier lifestyles, exercise, diet, and sleep. We can support policies that reduce inequality and improve living conditions.
So this is put out by the American Public Health Association, of which one of our guests a few weeks ago, Dr. Georges Benjamin, is their administrator. But I think this is a very important thing we know. But like she says, it's under attack by the current U.S. administration.
So,
It's-
Dr. Maxey, I think that this is a wonderful slide for us to stop today, but I would underline that we don't end it today because it says, maybe this is because I'm a pediatrician, but this has some very heavily laden recommendations, but we don't. This is the what, but we haven't talked about the how. And I think that we need to stop assuming once we identify the what, that the how will magically occur, especially right now. I think the American public is not aware. We think that they would be, but they are not aware. Just the fact that so many don't realize they're on Medicaid because Medicaid is called something other than Medicaid. We need to back up and I mean not today, but we need to back up and revisit this in talking about some really concrete ways the what can be done.
Yeah. And let me bring up, I'm going to say something that may be a little bit controversial, but we know that more than 17 million people are going to are going to lose their Medicaid coming up. I don't know if that's going to start in 25 or 26. But I have one patient. I have a lot of patients, but there's one in particular that comes to mind. He's about 50 years old. He hasn't worked since he was 26 years old, and he's totally disabled by his chart. But he's physically fit, he's 6'1" tall, and he's got a bullet fragment in one of his lower extremities. And he has pain occasionally. But he's physically fit. He could play a wide receiver for the NFL if he wanted to, but he's on Medicaid. How do we deal with that kind of patient? Is this what these people are talking about, taking away their Medicare? Let's comment on that. That's my view of this one patient. I have more.
Well, the problem is not the Medicaid. The problem is in the decision that he's disabled.
Which allows him to get Medicaid.
That's the vehicle. Yeah.
It's two different systems, though.
It's two different systems, but the reason he was able to get the Medicaid was because he was deemed disabled.
And we all know that the disability eligibility system is tremendously broken, because while you have that case of that individual, there's probably 10 more that should be disabled that didn't qualify for what else could I possibly write? What else do you want me to say? And part of it is the criteria for eligibility hasn't been updated in 50 years. Like, some of the stuff that they're talking about, what you're able to do and what qualifies you for disabled. Like, so I'm agreeing with Dr. Nabert Stevens. The problem with that in that scenario is not with the Medicaid. It's what allowed him. It is with the designation of disabled that allowed him to get into that position in the first place. And that is where we are addressing the problem with the wrong solution.
Mm-hmm.
So let me emphasize. First of all, Dr. Gibson had put his hand up a little while ago. I want to make sure we don't close before we get back to him. Now, Dr. Maxey, when you said maybe something controversial, really controversial for me, because I would want to come over there and fight you. And let me tell you why. If I wasn't so old and frail, I would come over there and fight you. Here's why. Because that example that you gave is the kind of example those people use to take everybody off of Medicaid and to make sure not. Yes, there may be one person who should be playing wide receiver instead of sitting on the porch smoking medicinal marijuana or whatever it is that person's doing. But every time one of those examples is highlighted and it looks like one of us, that is used to set policy that wrecks whatever limited resources are in our community. So, with much love and respect, stop talking about that man, because your comment is going to wind up someplace in a policy where they make none of us have any of the resources that we need.
Okay.
I wasn't really going to fight you, Dr. Maxey. I can't really
Okay,
fight you.
we can fight over it, but I have a very large practice, and these are patients that I inherited or came to me for special consultation, and it is rampant. So it's not just an isolated one or two people. And I agree that that gives the other side ammunition that they shouldn't have. But part of the problem is that some physicians have just said, "Oh yeah, you can have a disability if you want it. You can have disability. You can have the DMV give you a certificate. You don't have to walk." But part of the problem is that somebody in our medical system, a lot of us, have been lax in doing what we need to do, and it's come back to bite us in the butt, I think.
Completely agree, Dr. Maxey, that there are problems that we doctors need to fix. Those problems are not going to be fixed by taking the 550 or 500 patients that you have and taking 50 million kids off of whatever Medicaid help
I
that they
agree.
need.
I'm not talking about the kids. I'm talking about the gainful wide receiver adults.
But even in the premise of your question, the issue doesn't sound like I don't believe that these people should have health care, right? And
No,
then and
right.
because reducing or eliminating access to Medicaid, that's what that does, right? That's the solution that's being proposed. Oh, healthy, you shouldn't you shouldn't have the
I guess
benefit
what I'm
of
thinking
these
is
healthcare services. I know that's not
work
what you're saying,
requirement.
but
The work requirement.
that's where I was saying we are addressing the problem with the wrong solution, right?
Yeah.
If there is not, to my knowledge, I have never seen an like a reverse I have never seen the opportunity, to your point, to be able to say, because sometimes what was true at the time that the application was made, right? Because at the time that individual was shot or whatever, there could have been a whole slew of criteria that made him or her eligible for disability, right? And to your point, he may have made the best of his life, coped with his chronic pain, not let that be a barrier for him, X, Y, and Z, such that if he had to reapply now, right, maybe he wouldn't be eligible. I don't know, right? But I have never in my years of practice seen a form that said, hey, is this person still disabled from something that, like, I've never seen that.
Excellent point.
I'm surprised that Dr. Walks was being quiet about the fact that a lot of times Medicaid is serving as another way of saying that a person has an untreated mental disorder, usually anxiety disorder, pain, or post-traumatic stress disorder. These folks do. What do you do? What are you doing? These are treatable conditions, but we don't get those conditions treated because we're saying, well, we'll give them some money and tell them stop working or stop doing other things. When in fact, many of these folks, sure, they're physically able, but because of their ongoing chronic mental problems, they really cannot function in an effective way in most jobs or any other situation. So part of the big problem is that we're having decision making about how to allocate health care resources, but it doesn't take into account all of the needs, the issues in terms of substance abuse and mental health, that leads to the idea that, well, perhaps we got a whole bunch of healthy people running around and we're just paying them to stay sick.
Dr. Gibson, open.
Yes, and thank you so much. And I would it rhymes with Amen Walls, but I'll say Amen Dr. Walks. Your assignment, everyone, under the sound of my voice, is to click on Blue Zones in the chat and watch that right after this presentation, please. Thank you.
Tell them what blue zones are, Dr. Gibson.
Blue Zones is a detailed description. I'm not going to give it away. It is a detailed description on how to live long and well, and emphasis on the well.
Okay. And for those of you, it's another reason to move to California because there's a big blue zone out here. Okay.
No, I'm sorry, Dr. Maxey. You said blue zone. I think you meant ozone.
No, blue zone.
As
Blue
in
zone.
small. I think I'm messing with you, Dr. Maxey.
I used ozone when I was an undertaker.
Oh,
Thank
God.
everybody for joining with us on this Sunday. Next week, we're going to be at the National Medical Association and possibly have a number of interviews with the leadership of the Black Physicians of America. See you next week. Thank you, Simon, very much. Have a great day, everybody.
Blue
Thank
zones.
you, everyone.
Bye.